Hi, thanks so much, Melinda, and thanks, Shelley, and thanks to everyone involved in setting up this conference. I'm so excited for this panel and the next few days. So I'm Jane Dryden, she, her. I'm blonde. I've got glasses. I've got puffin earrings. Puffins are great. I'm from Mount Allison University in New Brunswick, Canada, which is Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people, governed by treaties of peace and friendship going back to the 18th century. So I'll be chairing this panel on the politics of identity and identification. And I'm very excited I'll introduce each of the speakers in turn as they're about to present. So our first speaker is Caroline Christoff. She is an assistant professor at Muskingum University. Her interests are in philosophy of disability and bioethics. Her recent work includes performative trauma narratives, imperfect memories, and epistemic harms, and the cyborg nature of cognitive disabilities, an existential analysis of rationalist frameworks. And in her spare time, she goes to many fan conventions and hosts the Con Couple podcast, which I am going to check out. Her presentation is called The Normativity of Neurodiversity, How Atypical Behavior Impacts Identity. All yours, Carolyn.
So, hi, I'm Caroline Christoff, pronouns she, her. I'm a white woman with long blonde hair. I'm wearing a pretty big headset and a maroon coat underneath. Just also in the interest of full disclosure, I mentioned this to Jane already, but I'm having surgery at 11:30, so I have to leave this panel a little bit early, and I also have to take a pill in about 15 minutes to prepare for that. So I probably won't be around for the full Q&A, but I'm hoping if this surgery goes well, I'll be around for the rest of the conference so people can catch me there. And if you do have any questions, I'm sure my email will be shared with people. So I appreciate everyone willing to work with me on that. With the snowstorm that's just happened in my area, it's been a bit helter-skelter about getting the scheduled, and this was just the only time that worked for people. So my presentation is called The Normativity of Neurodisability, How Atypical Behavior Impacts Identity, and it's primarily looking at the neurodiversity label as it occurs in society generally. So just to start with the basic terms, I'm not doing anything like, I guess, avant-garde here. Neurodiversity is what it sounds like. It refers to conditions like ADHD, autism, and a few other things that are on the spectrum generally. Um, And neurotypical refers to people who don't have those particular conditions. And what I'm doing is examining those particular things to see how those terms work. So, part of what I'm looking at here is what is the purpose of labeling? And I am going to be comparing these labels to other labels such as womanhood or ethnic labels. I do want to emphasize that this is not an analysis of how we use terms like womanhood, ethnic labels, anything like that. It's just meant to be a comparison piece. So I'm not giving it a definitive account of what we mean by woman. I don't think anyone could do that in 20 minutes for a presentation. But I'm looking at the purpose of how those social labels form, how we use them. So, when we label somebody as a woman or as a person of color or as a person with a disability, what are we doing? What is that function does that label ultimately serve? There's a number of functions. Here's a very non exhaustive list. One is just self understanding. Those labels help us understand ourselves and how we relate to ourselves as people. Also, other understanding that gives us ideas about other people, how those people might act, what they might have gone through, stuff like that. Elizabeth Barnes and a lot of other people have worked on the pride of being labeled as disabled or being labeled as a certain group where you feel this collective pride about it. It also obviously occurs prejudice a lot of the times. Most of these labels are stigmatized and produce prejudice. We use these labels for diversity in terms of perspectives a lot of the time and making sure we get diverse perspectives. They're part of our identity. Most of us consider our gender identity to be very core to who we are. Some don't, some do. And there's also collectivity, which allows for collective action. And all these purposes, probably outside of the prejudice, are good. But there's this question of how they're constructed and how different labels change which one of these functions are most salient when we're talking about these labels. So, all social labels, when they've been talked about by philosophers, have had various functions, and they tend to privilege one of the functions that I've talked about over others. So, here's this very famous definition of womanhood that we've seen from Sally Haslinger, where it says that basically, I'm not going to read it verbatim because that'd be kind of boring, but basically, it says that S is considered a woman if they have the appearance of being a woman and also satisfies a subordinate position in society. And this very clearly isn't meant to pick out all aspects of womanhood, nor do I think it's Haslinger's project to pick out all aspects of womanhood. Rather, it's attempting to give a label that explains why woman as a class of person is discriminated against, which is good. There's a lot of things that that label serves to do. It explains that woman's a subordinate class in society and that people who have certain gender markers upon their bodies or appear to be a certain gender are women. What it doesn't do is talk about like the pride of being a woman. And it's also going to leave out some experiences of being a woman. So, for instance, a trans woman who's not yet out might not yet experience this particular type of prejudice. They probably experience other types of prejudice insofar as like being a closeted trans person. I'm sure it comes with its own form of prejudice, but they don't experience the prejudice of being a woman yet, which makes the term problematic, right? Because they both are a woman in terms of identifying as a woman, which is very important, but they're not in terms of experiencing the social prejudice that Haslinger is talking about, which leads to epistemic confusion because that definition is privileging some functions of the term woman over other functions of the term woman. Which again, is not necessarily bad. I don't think there's a definition of the term woman that can get in all of the functions of what a woman is supposed to be. But we do need to be cognizant of the fact that anytime we give a definition, it's going to be privileging some functions over other functions. We also see this with Barnes's model for physical disability. If you've read her book, The Minority Body, where she suggests that somebody who has a physical disability is in a bodily state, and that bodily state is among the things that the disability rights movement wants to protect. So this shares some features with the Haslingerian model insofar as both of them say that the label in some ways has what's called a defeating condition, which I'll talk a little bit more about. But basically, what a defeating condition is a condition that means that you can't just decide for yourself that you are a given label or that you can be wrong about it. So in this case, somebody has to be in bodily state X. They can't just decide for themselves that they are in bodily state X. It has to be something that is somehow external to their own self assessment of themselves. And like the Haslingerian model, it also privileges some aspects of social definition over others. In this case, and Barnes is very clear about this, she's trying to give a model that is about disability pride rather than talking about a model about discrimination itself. So her model is going to be focused a lot more on people being part of the pride movement and a lot less about who's experienced discrimination. Whereas Haslinger's definition of womanhood is going to focus on the prejudice of having to be in a female body over it is the pride experiences. So I've also made my own attempt at a neurodiverse model. I don't think this is a particularly good model, but this is just an example of how we could describe somebody as neurodiverse. So somebody is in mental state X. And if they're in mental state X and the neurodiversity movement classifies state X as a condition that they care about and want to support, then they are considered neurodiverse, basically. So this is, again, not, I think, a terribly good definition, but gives you an idea of how we could come up with a definition of neurodiversity. And there's problems with it. So one of the problems you have with all of these models is what I would call defeating conditions. So defeating conditions are basically conditions by which somebody can legitimately believe that they have a condition, but not actually. So Barnes brings this up in her book and considers it to be something that's worth talking about, and it does have some purpose. So she considers a defeating condition to be a condition for which you could be wrong about having a disability effectively. So, for certain purposes, conditions having or social identities having defeating conditions is important because you don't want somebody claiming to be part of a given category uh, just to gain the benefits of being in this category. So, for instance, claiming to be disabled so you can like bring a service dog anywhere, even though you're not, which I sort of get. But at the same time, defeating conditions also lead to problems for particularly things like identity claims, right? For identity, if you legitimately believe that you are a condition, it seems like you should just be that condition because it's something you want to be. But at the same time, if you are that condition but don't appear to be that condition, you're not experiencing the prejudice function of the identity. So basically, defeating conditions work for some functions that we want these terms to serve, but not others. And that leads to a lot of fairly complex problems. So, for example, trans woman that's not out yet, that person absolutely should be a woman in terms of identity, but they haven't fully experienced the social prejudice of being a woman, even though they've experienced other social prejudices so far. how do you manage that is kind of a very big question. And I want to be very clear. Trans women, whether they're out or not, are absolutely women. But part of the problem we're dealing with these epistemic language conditions is because we want them to do so many things, we're getting into these weird kind of labeling contest about who is what that's leading to a lot of, I think, both epistemic and normative problems. Making that over. So, additional problem is that any rigid definition of a term is inevitably going to privilege some of these epistemic and normative functions over other elements of these functions. So, it's going to privilege identity over the experience of prejudice, or it'll privilege the experience of prejudice over the experience of collectivity. And that's going to lead to definitions that get in some people and get out other people based on what the definition is trying to do. And that's bad because mislabeling people can lead to sort of epistemic and normative problems, such as the issues with trans identity. And it can also further exacerbate the idea that these different labels are constructed differently. So even though racial labels, gender labels, sexuality labels, disability labels all serve these various functions, they don't all serve them to the same degree. So, for instance, racial labels likely focus more on collectivity than they do identity because the shared experience of being prejudiced against is a very large part of racial identity in a way that is a lot more unique for gender identity, so they tend to focus more on identity politics. It's just kind of a toy way of thinking about it. I'm not necessarily committed to that claim, but all of them do function a bit differently. And this gets to a bigger problem when we're talking about the label of neurodiversity or having a neurodiverse condition such as autism or ADHD or something along the lines of that. For these conditions, one problem we have is the defeating conditions are very, very weird to the point of almost being nonsensical. So, for physical ailments, for instance, if you legitimately believe that you have cancer and act as though you have cancer, you can't like make yourself get cancer. But if you legitimately believe you have a condition such as ADHD, you act consistently as though you have ADHD and display the behaviors associated with having ADHD and would probably at that point get a formal diagnosis of ADHD. Do you just have it at that point? Is that any different than somebody who just displays all those behaviors naturally? So that's a problem. How does that defeating condition work when we're talking about neurodiversity? And the second aspect of it is this is a very medicalized process. A lot of other labels aren't medicalized. Some disability labels are, but generally sexuality, gender labels aren't. Medicalization just means that generally doctors get to define whether you have it or not. And that's been the case for most of the neurodiverse labels for a while, although it is changing. So, a lot of you have probably seen a chart like this. This is just a very basic autism spectrum chart, has all the different things that could qualify you as being on the autism spectrum on it. Jen, not bad, goes through a lot of different things. But it does lead to a lot of problems when it comes to the medicalization problem and the spectrum problem. So, defeating conditions generally suggest that there's some underlying cause that a person can't just make up themselves that in some way connects to a given social role or social label. It's not necessarily the social role or social label itself, but it is something that is a social role or social label for purposes of understanding it. So, for instance, sometimes being blind is not the disability, but it is something that leads you to have a disability under some models. There's some connection between the two. The problem with the neurodiversity spectrum, particularly spectrums like autism, and it is implies that there's some underlying truth about whether or not you have a condition like autism, while at the same time having a very extremely vague set of criteria behind that. Whereas there's not an exact amount for how much you need to be considered autistic on the spectrum. I'm sure if I was to ask anyone in this room, you would probably be somewhere on some of these. So, for instance, like my husband has like a moderate amount of sensory aversions, doesn't like avocado. Is that enough to make him on the spectrum? These are things that aren't easy to decide either in the medical community or out of the medical community in terms of context. And because it's so vague, you really can't limit yourself to having a standard definition. 1 second. Yeah, thank you for your patience. So, removing these defeating conditions is something that we could do. So if we just removed the defeating conditions and allowed everyone to identify as neurodiverse or not neurodiverse, that probably would help with identity claims. But that also still leads to problems because if we're talking about neurodiversity in terms of a person who is neurodiverse experiences the prejudice of neurodiversity, if we have anyone claim that, then we're going to have people who don't actually appear as neurodiverse not experiencing the prejudice of neurodiversity, even if that claim is helping them with identity. More deeply, the options, if we legitimately do believe this is a thing or a trait that is external to somebody that they can't decide just for themselves, our options are either letting doctors decide or we're randomly evaluating people on their behavior. Neither of those options are great. So basically, we're stuck with kind of three different ways of evaluating this. One is self evaluation, which would allow, I think, for a lot of healthy claims in terms of self identity, but might underwrite the prejudice of what it is to be neurodiverse. You could have it be medicalized as it currently is. That's going to often leave out people who legitimately feel like they're neurodiverse and also leave it kind of subject to a lot of bias given the vaguity of the criteria. Or we can let individuals also determine other individuals in their lives, I guess, decide for them. That's probably, I will be honest, not a great option generally, because then it's just going to be based off observation. And that's also not great a lot of the time. So, what do we want the neurodiverse label to do? Because that's going to help answer, I think, some of these questions. So, like with all other labels, neurodiversity has certain functions. These are the ones that I've just been kind of categorizing as most important to it. So, for instance, prejudice, this happens just to anyone who appears neurodiverse. They're going to experience some prejudice as a result of their condition. Pride or collectivity, that's their ability to kind of advocate for themselves. Accessibility, uh, the big thing, particularly I think about labels that involve disability, is having the ability to acquire resources for the self. Identity, which is self understanding, the neurodiverse label helps a lot of people. And other understanding, which is understanding others as they go along. So we want these labels to do these things. Big question is, can they? And as they're currently constructed, can they do any of these things well? So, one problem you have with this is the obvious vagueness problem. Due to the broad variety of spectrum that is neurodiversity, the label of neurodiversity might not appropriately fill any of these functions as well as more fine tuned labels might. So, the pride in the neurodiversity movement right now has a very big problem insofar as that it's very focused on individuals who are good at advocating and need the least amount of help because they're the ones who have the capacity to talk the most. And that's largely been who's leading the neurodiversity movement currently. And that's not bad. Those groups of people need help. But people on the neurodiversity spectrum with sometimes what we consider more extreme needs often either have their voices either by their parents who aren't always great at voicing their needs or by other members of the community, which is possibly better, but they still don't know the exact experience that somebody who has very different needs than them is going through. And it's also hard to advocate for access when we have no idea what type of access we need and in what context because of how many things the neurodiverse label includes. And moreover, these broad terms can lead to confusion over self understanding and other understanding. Now, you might be thinking, well, aren't all identities like this? We think about the label of woman. It's not as though there's just one type of woman out there that exists. There's thousands upon thousands. And that's true, but there's a very distinct problem, particularly with neurodiverse identities, that doesn't occur, I think, even with physical disabilities to the same extent that it does neurodiversity, which is that neurodiversity, by and large, when it's labeled in the public, is behavior based. Everything about your neurodiversity is determined by behavior. The tests for it, for the most part, are just determined by observing people. So it's something that is labeled primarily by watching people either observe your behavior and labeling you as that, or you reflecting on your own behavior and thinking if your own behavior matches that, which isn't something we can really do. Like if we were trying to come up with a list like this that was like the woman spectrum or the people of color spectrum, it would understandably be horribly sexist and horribly racist because we don't consider that to be something that we should characterize in terms of behaviors. There are obviously some behaviors we associate with being a woman, but just because we have some behaviors we associate with being a woman, there's not like a list of behaviors women people have to fulfill, whereas they do with disabilities or neurodiversity, which leads to all sorts of problems. So this leads to the issue that generally, if we're clustering behavior, that leads us to a lot of bias very, very quickly. This is part of the reason why personality tests tend to be quite popular despite not being very scientifically based. This might be my little own vendetta against personality tests, but Myers-Briggs, Enneagrams, astrology signs, stuff like this, they label people's personalities. They have no basis in actual scientific theory whatsoever. Myers-Briggs is based on a bunch of false dichotomies. Enneagrams, there's no suggestion that people actually fall into those different types of people. Astrology signs are those astrology signs, but people gain a lot of self-understanding by these types of things, regardless of whether or not there's actually any scientific basis. And I think there's a very big worry in the neurodiverse community right now that because it's becoming as prominent as it is, while it is generating more epistemic goodness in the world, it's also generating a lot of epistemic confusion because of how much people are playing into the stereotypes of being neurodiverse. And this is a problem that you're going to have with any class of label that is entirely behavior based. It's going to lead to more biases because if you're told that you're going to exhibit a certain behavior, you're probably going to exhibit that certain behavior, whether you are or not. And this leads to problems with advocacy. So, yes, it's true that neurodiverse behaviors probably do cluster in a way that astrology signs don't. Like, there probably is more factive base to the fact that these behaviors for things like autism or ADHD do cluster, whereas I don't think astrology signs actually do cluster. There are still problems with it. So, for any non behavioral label, a lot of what you're trying to do with that is overcome stereotype. But with behavioral labels, you're both trying to advocate to get better resources for that behavioral label, while at the same time also mentioning that not everyone with that behavioral label exhibits those particular symptoms. So, for instance, you might want to try to advocate for quiet rooms for people with autism, while at the same time mentioning that not everyone with this condition does that. That's not a contradiction. Both of those things could be true, but it is cognitively difficult to talk about a lot of the time. And it is something for which the label of neurodiverse, I would question in these moments if it's actively doing more normative and epistemic good than it is harm. Because it seems like it would be clearer to talk about the symptoms of neurodiverse conditions as opposed to just the neurodiverse conditions themselves, because that would be a lot clearer in terms of A, what people need, what they don't need, and wouldn't lead to people with wildly different symptoms being grouped together as much as they were. So, given the wide variety of neurodiverse behaviors people experience, the other problem you have with this is again advocacy. It's because you're typically going to get people who are very verbal advocating for what the current movement should be in the neurodiverse community. And that's going to be a very big problem for the people in this community in particular who are nonverbal, because their interests are either going to be advocated through, again, either their parents or through some person who's advocating for them. And because of how diverse this community is, there can be a wide variety of different interests. And I will say that there is a very big problem, or at least I feel there's a very big problem right now, of people who were diagnosed as adults overestimating their knowledge about what it would be like to grow up with a disability like this, in part because they don't have all the symptoms, and in part because of this other problem, which is the label of prejudice itself. So, autism carries with it a form of prejudice that goes beyond the simple prejudice against the behavior. We can obviously be prejudiced against a behavior, but you're also prejudiced against the label itself. So, as somebody who's been labeled autistic since birth is going to have to deal with a level of prejudice against the label itself, in addition to a label against their behavior. So, for instance, if a person's labeled autistic and told that they don't want to take a pill, they'll be considered irrational. Whereas a person who's not autistic, even if they happen to later discover they're autistic in life, won't be labeled as irrational. And part of the problem with this is this creates problems with the function of the neurodiverse label when we talk about prejudice. Because people who were diagnosed earlier might experience the prejudice not only of their behavior, but also the prejudice of being labeled as autistic or ADHD, whereas those that were diagnosed later in life, while they might have experienced some prejudice insofar as they have the behaviors, aren't experiencing the prejudice of being labeled as neurodiverse. And this leads to wildly differential experiences. One, in terms of how much pride they take about the label. Generally, people who are diagnosed later in life tend to have a lot more pride in their condition than people who were diagnosed earlier, because the people who were diagnosed earlier know the prejudice that they might experience by revealing their diagnosis, as well as doesn't get to the fullness of the experience in a lot of cases, given the wide variety of functions that this label occurs. So, do some kind of final considerations with this. I recognize that the neurodiverse label isn't going away. I don't necessarily think that it needs to. However, I do think that it's something for which we need to fully kind of embrace complexity a little bit more than we have been in society. I do think it's useful for some people identifying as neurodiverse and knowing their specific conditions can help them a lot and can help with their advocacy a lot. However, I will say for me, as somebody who's dealt with kind of a struggle with this their entire lives, I also think there needs to be respect for people who are like me, who just fundamentally reject the neurotypical, neurodiverse binary as meaningless to their self understanding. Like, I don't find that label, given its broadness, to be something that's particularly useful to me in my life as it currently is, and whether or not it's true. So, it's something for which I think that we need to recognize that not all identities necessarily need to fall along this binary spectrum if that binary spectrum just doesn't work for somebody. It might be easier for them to talk about it in other ways. And some other ways I would recommend people would talk about it is rather than focusing on neurotypical or neurodiverse, is talking about some of the functions of the label more specifically. In some ways, you can do this is by not talking about neurotypical or neurodiverse, but some specific things that are associated with neurodiversity, such as somebody being nonverbal or experiencing sensory aversions. I think that these types of tools can get you to a lot more specific advocacy in a way that can help more generally. And generally, I believe that these levels do serve complex social functions, and we do need to realize for all sociological labels, when we're using them, generally we're privileging one function over others. Sometimes when we say the word woman, we're talking about the prejudice that women experience. Sometimes when we're saying the word woman, we are making an identity claim. And being more clear about how and when we're using these terms, I think, can lead to a lot more beneficial advocacy in, I think, society generally, especially in the disability community right now, where there's a lot of, I think, epistemic confusion going on. So,
Great. Thanks so much for that. We've got between your own availability and just time for everyone, we've got about 10 minutes for questions and answers. And there's already a couple in the they're popping up right now in the Q&A. There's two from Hypatia of Sva, and I'll read both of them together just to kind of keep things moving. Um, so the first one is, would you say the issue here is that we can even, would you say the issue here is that we can even try to find strict logical definitions for colloquial terms? Where does the need of managing relation to a book based on a textbook definition come from here? So what's the kind of like purpose of having those sort of strict logical definitions for colloquial terms? And then second question, uh, also, I'm confused why you're saying a person is neurodiverse. Would it not be neurodivergent, with neurodiversity covering the complexity of both neurodivergence and neurotypicality? And I don't know if you saw in the chat, but there was some sort of follow-up discussion about the terminology. So, hand that
yeah, the
over.
terminology I will say I'm pretty open on generally. I think either works, whatever works for people generally. The issue I think with trying to come up with terms right now in the neurodiverse community is just that there has been a lot of gatekeeping around it generally. And with the advocacy movements generally, there is a very big question right now of, does this need to be medicalized? And if it does need to be medicalized, should there be a certain term for it? And I think there are a lot of advantages of not making it medicalized anymore and just allowing people to identify as neurodiverse if they want to. But some risks that you have with that is that if anyone's allowed to identify as neurodiverse at any given time, you might have the term become more and more broad such that it's harder for particular people to talk about their particular experiences because their experience of neurodiversity might be very, very different from yours, which if we can get the collective understanding that that's true, that neurodiversity is like womanhood, where it's just that broad, great. But because it's also attached to a bunch of accessibility stuff right now in terms of what access people need in like colleges and stuff like that, it's, I think, a lot harder. That said, for me, and I think for a lot of other disability advocates, the best type of access is just access for everyone, where everyone can just have access all the time. And you don't never have to ask for it, but we're not there yet. So,
Thanks so much. All right, next question is from your co-panelist, August. I'm wondering if you think that neurodivergent identities have to be classified in terms of behaviors rather than underlying mental differences that are stigmatized, and if so, why? Might the reason we classify based on behaviors just be due to epistemic problems we have since we can't see differences in the ways people's minds work directly?
so I have looked a little bit into like the actual neurology of this. And there are studies that show that some people's brains obviously do operate in ways that are different. I'm not going to get too much into the science of it generally. Uh, my question with that generally is that just because we don't do brain scans generally, at least right now, if somebody displays the symptoms of being neurodivergent, then they're going to be labeled as neurodivergent. The other problem you have with this is just because neurodivergence is actually a series of diagnoses, you're going to have several different diagnoses that might have different starting points, but be diagnosed similarly in terms of neurodivergence. Like, for instance, autism and PTSD have a lot of the same symptoms. They're not considered the same condition because one has its basis in trauma. The other is considered to just be something that happens biologically for the most part. But because their symptoms are the same, does that mean that they're the same disorder? Why or why not? And I think those are really complex questions that you could answer.
Great. Thanks so much. All right. Next question from Melissa Fox Muraton. Thank you for I'm not sure if I got your name right. I was taking a cue from the accent. Thank you for this engaging presentation. From my understanding, the neurodiverse label attempts to account for the fact that many people fall under more than one diagnostic category, and that this can obviously affect needs and traits. For example, ADHD, so autism and ADHD, might present differently from just autism. In this context, do you see this term as pertinent for accessing support in education, work, and etc.?
Part of the reason why I don't think the term is going away anytime soon is because of how prevalent the term is right now for accessing the community. My concern with it going forward is just because it means so many different things. I do think we need to start recharacterizing it in terms of specific needs because it can lead to a lot of epistemic confusion if you just say, go to your university, for instance, and say, I'm neurodiverse. That's not going to give them a lot of information. You need to say, I'm neurodiverse and I need X, Y, Z. And again, a large part of this is just the problem is because we're trying to advocate for so many different things at once, it can lead to, I think, some confusion about what we're trying to advocate for and when. That said, I think the term is useful right now as a heuristic for at least understanding that you have more than one need or complex needs, and that's absolutely great. But the best type of self understanding is going to be understanding exactly what those needs are as opposed to just a broad term for them.
Thanks. I'm just going to Oh, sorry, I needed to scroll down. So there's two more questions in the chat. So Julie, maybe terrific presentation. Thank you. Is there an inside outside issue here? Is there a distinction between someone who feels some condition and someone who acts or behaves it? Scare quotes around all those terms. Can someone fake some condition in behavior?
So I've thought about this a lot. Part of the issue I will admit I have in my own life is because I have complex trauma in my past. I then operate in terms of like symptoms that I would expect to see. And sometimes I wonder if I've never heard or had those symptoms written down, would I ever display those symptoms? So I do think that there is, and we do know this psychologically, if you're told you're going to be a certain way, you're automatically going to start acting a little bit more that way. It's very hard for you psychologically to not to do that. That said, I don't know if you imagine somebody who just decided they want to have ADHD or something like that for whatever reason and just focused really hard on acting like they had ADHD. And at a certain point, you might question, are you just giving yourself that disorder at that point if you just have those particular symptoms? Is that somehow different? And a very big question I think we're still answering in this community right now is, do these conditions have to have some underlying like biological, neurological cause? Or is it just the behaviors as they're displayed, given that we can't really evaluate that biological underlying neurological cause yet?
Thanks. Next question in the Q&A from Ed Smith. There seemed to me to be something strange in the use of solidarity in the early models of definition, in that they appeared to focus on how to exclude individuals from a group so defined. Am I wrong to read the idea that only correctly identified members of a group can stand in solidarity with that group as implicit in this approach, the early models that you used in the presentation? And could this be a reason why accessibility questions are not understood on your preferred model of accessibility for all?
Yeah, I do wonder a lot about that. A lot of the readings I did on this, which are back from, I guess, that time period where we were doing this, did seem to be very kind of obsessed with this question about somebody like faking a condition, which is not something that's ever going to realistically, I think, happen, at least long term. Like maybe you're going to get the odd person who fakes having a service dog occasionally, but you're not going to get somebody who's consistently trying to be ADHD their entire lives. So there is this wonder, and I do question it, about whether or not we need to have these defeater conditions or whether or not we can just trust people to just say what they think they are a lot of the time. Because there is, I think, a very big problem in the medical community right now of assuming that people can't be experts on themselves. And I do think that's one of the biggest problems that's in, I would say, particularly the neurodiverse and kind of intellectual space generally, because we are with ourselves all day. So you probably have a better understanding of like what your strengths and weaknesses are than a doctor who observes you for an hour.
Yeah, no, that makes sense. I'm just going to share a couple of comments that have come up from the chat. So Julie maybe points out language and concepts, of course, shape the way that we identify ourselves too, and those are social, which links back to your early point. Bailey Shustak writes, I will recommend Dr. Nick Walker's work, blog, and book, Neuroqueer Heresies, for essays and commentary on terminology. And Hypatia Sva says that last point reminds them of the whole fake claiming discussion in the plural context as well. And I'm looking at the time, and there's no more questions in the Q&A section. And I think
Cool.
unless there's anything sudden that comes up in the next minute.
Thank you. This was
All right. So everyone thank Caroline for her presentation, and sorry to lose you imminently. I hope everything goes smoothly.
sorry about this chaos. I appreciate you guys for being so patient with me.
All right. Okay. What a great start. Okay. So our second speaker is August Gorman. Sorry, I've got so many things on my screen right now. Our second speaker is August Gorman. He is assistant professor of philosophy at Oakland University and is excited to be teaching his university's first Intro to Disability Studies class next year. That is fantastic. Audience members might also be interested in checking out their recent publication, Against Neuronormativity in Moral Philosophy, in Moral Responsibility in Feminist Philosophy Quarterly. And so his presentation is called Am I the Problem? Reframing Perceived Burdensomeness in Suicide Prevention Ethics. So all yours, August.
Thank you so much. Okay, let's see. Thank you so much. Okay. Hopefully you can hear me now, and then also see my slides. Yes.
Sorry, we've just lost your slides, August.
Whoops. Okay, let me try that again. Here we go. Do we see my slides now?
Yes, thank you.
Excellent. Thank you so much, Jane. Okay, so thank you so much for that introduction, Jane, and thank you to Shelley for the invitation and for everyone for keeping this incredible conference going. I am August Gorman. My pronouns are he and they. Either one is fine. I am a white, non-binary trans man with a long beard and glasses. I'm wearing a mustard yellow sweater. I have a blurred background, but I am speaking to you from my home in Detroit, which is the colonized ancestral land of the Three Fires Confederacy, the Ojibwe, Ottawa, and Potawatomi, as well as the land of the Wyandot Nation. I have a content note for this presentation, although the title really gives it away, but I will be talking about suicide, and in particular, I will mention trans suicides, so please do what you need to do to take care of yourselves. There is a dyslexia and screen reader friendly version of my slides at tinyurl.com/Gorman slides 2026. That's tinyurl.com/GORMAN slides 2026. There's also a QR code that will remain at the top left of my slides that will also get you to that version of the slides that I have. Okay. So again, my presentation today is called Am I the Problem? Reframing Perceived Burdensomeness in Suicide Prevention Ethics. So just to situate this talk a little bit, it's part of a bigger project that asks the question, should a diagnosis of clinical depression change anything about the ethics of suicide prevention? And my answer to this question is a very qualified yes, sometimes, in some ways. And in the longer piece, I look at sort of three different reasons why. Um, someone's having a diagnosis of clinical depression might change something about the ethics of suicide prevention. Probably most classically, I look at the impact that clinical depression might have on rationality. I then look at the impact that clinical depression might have on volition or the will. But in this talk, I'm going to focus on the third potential reason, which is because of the impacts on self stigma that a diagnosis of clinical depression might have. And I've got a star next to that potential reason. Okay. Excuse me. Okay, so what I want to do first is sort of build the foil to my view. So here's the idea. Something like this could be a reason why someone would say a diagnosis of clinical depression impacts the ethics of suicide intervention. Suicides aren't really caused by people having reasons for them. They're usually caused by the disease of depression that overtakes someone's agency and rationality and makes people make decisions that are completely disconnected from themselves. We simply need to get people with depression to realize that they have a disease like any other, treat it with medication, and help to correct the person's irrational thoughts stemming from their illness. Problem solved. Okay, on this slide, I also have a picture, and it is of a sort of forlorn woman standing in and interestingly, completely blank field. There's nothing else around her, no social context whatsoever. And she's holding a black balloon that has two eyes. And this black balloon is meant to represent her depression, this thing that is wholly outside of her, causing her problem. If she could only be rid of it, wouldn't that be great? And this is from, I believe, a print ad for Abilify, but there are also television commercials. Um, and I thought it was sort of fitting here as this idea that this is something wholly non-self outside of you. All we have to do is sort of get rid of that thing, problem solved. Then you go back to your own self with your own reasons, which have nothing to do with suicide. Okay. Um, so that's the foil to my view. That's not the kind of reason I think that we ought to treat um cases where someone has clinical depression as different. Um, but I do want to mention the following thing. Even if we took on a completely medicalized view of depression, it's worth pointing out that depression can have severe symptoms. It can sometimes be treatment resistant. And this alone would give someone a reason for despair that's not wholly irrational. So even if we take that fully medicalized view, we needn't say that there's this like outside entity that's completely irrational that's taking over your autonomy. Okay. But what I want to focus on now is this. Some of the diagnostic effects of actually getting diagnosed with clinical depression, things that come along with getting a diagnosis. And one of those things tends to be pessimism about recovery. So that it's a disease like any other sort of framing of depression doesn't really help with stigma or self-stigma as much as advocates of it might have hoped. There's it it can do a little bit in that regard, but one of the findings has been that it actually increases pessimism about recovery. Another thing relatedly is that anytime you introduce the language of disease, many of us in this audience will know you implicate illness stigma, which is very strong and strongly associated with notions of disgust, shame, and burden. Excuse me. Another diagnostic effect here, individualism. So, another thing that getting a diagnosis of clinical depression does is it sort of puts us in a world of what I'm going to refer to as pro desirability norms on our emotions rather than pro warrant norms. So, let me unpack what that means a little bit. Pro desirability norms are about whether our mental states are good for us, and pro warrant norms are about whether our mental states make sense. So you can think about perhaps would it be good for you to forgive someone um, just for you versus does that person deserve our forgiveness, right? And so I want to quote here from a really great piece by Michaela McSweeney called Maladjustment about um, what these norms sort of do. So here's the quote. As wielded by an ideology of individualism, our current pro desirability norms focus most of our attention on an agent and her internal states. This leads us to see her as an isolated individual whose agency is not impacted by or shaped by the world, thus serving to reinforce the idea that we are all self made individuals whose successes, failures, poverty, wealth, and so on are entirely due to our individual agency and have nothing to do with the relationship between us and the broader social world, social systems, and structural injustice. Okay, so to bring some of this together, one thing that you might think would be an appropriate response to someone who has clinical depression, who is displaying suicidal ideation, might be something like the following. Hey, I can see that you're not happy right now, but someday you won't feel bad anymore, and you've got a bunch of good years left. Like, imagine a good day and then another good day. It's just hard to see that those days might be here. And you know what? There is some truth to that. So, for one, immense suffering can induce a kind of evaluative tunnel vision. And there are some findings in psychology about clinical depression correlating with a difficulty in specifying futures in a lot of detail. So there is a restricted scope of future possibility that a person can imagine who's in the throes of clinical depression. So it might be, right, that a person can't see the potential of having a good day or a good year. But just because a person has depression, though, it doesn't mean they're necessarily making a mistake in reasoning. So, what I want to suggest is this: sometimes it's not that the person can't imagine the possibility of a good day in the future, it's that their decision to die is an answer that responds to a different kind of agential question. So, what do I mean by that? Now I need to introduce my distinction between two different kinds of agential questions. So, the first kind of agential question is sort of the more common one. Um, Something like, what is the thing to do in this situation? This is the question we tend to think of agency and practical reasoning as answering. It includes questions like, do I really want to cook dinner tonight or would I rather just order in? It's about momentary choices. Okay. Um, But now I want to introduce a distinction between additivist and holist perspectives on lifetime well being. On an additivist view, each moment of your life contains a certain amount of pleasure, pain, desire, satisfaction, objective goodness, whatever the thing is that you think well being consists in. Each moment has a certain amount. You simply add each moment together, and then you get your lifetime well being. On a holist view, however, lifetime well being is a function, at least in part, of non additive factors that are about your life when conceived of as a whole. So, I'm going to offer two really brief arguments to try to get you in the mindset to see that some of these holistic factors about your life conceived of as a whole might matter to what you decide to do. So on this slide, I have two graphs that I will try to describe as best I can. On the left side, we have a graph that indicates a person's life that's, let's say it's like a normal-ish length, maybe a little bit short, but it has a pretty high level of momentary well-being at each of these moments. It starts around 5, and then it goes up. It generally goes up, it dips down a little bit, and then it goes all the way up to a pretty high level of well-being, and then the life ends. On the right-hand side, we have a graph where there's a smaller hump of well-being. It's not as much as in the other graph. It goes from 5, and then it goes up to 15, and then it slopes down pretty quickly to just above 0. So that means just barely in the positive. Life is worth living, but barely. And it stays that way for a very, very, very long time. Now this is called the interpersonal repugnant conclusion. It's like a footnote in Derek Parfit's Reasons of Persons. Um, but the point I want to take away from this is that I think many of us would prefer the life on the left-hand side to the right-hand side, or if not, we could at least understand someone having a preference between these two lives. Even though if you add up each moment, let's suppose you get the same additive level of overall well-being in the life. Okay, That's my first argument. Here's a very different argument. I want to talk now about the Leila Alcorn case. So Leila Alcorn, if you don't know, was a young trans woman who died via suicide. And in her suicide note, she said the following, quote, "My death needs to mean something. My death needs to be counted in the number of transgender people who commit suicide this year. I want someone to look at that number and say, that's fucked up, and fix it. Fix society, please." Now, as a result of her suicide, several cities in Ohio banned conversion therapy. So it did have an effect, right? Here's my question. Would it have been better if Leila Alcorn had one more day of life that was relatively happy and then died the next day in an accident? I don't know. I'm inclined to say maybe not. Now, I want to caution here, though. I don't want to overly glorify suicide. What I want to say instead is the following. Um, and please excuse my extensive use of quotations from this paper that I really think is great. It's by Jeffrey Anslus and Jennifer White. It's called Critical Suicide Notes on Witnessing and Prefigurative Politics. And they say the following: "For those whose lives have been systematically devalued through colonial, genocidal, heteronormative, and white supremacist logics, death is ever present, and suicide can become an extreme, albeit tragic, form of political refusal. However, recognizing that suicide may be framed as a form of political refusal does not mean endorsing it as a desirable or inevitable response." And two things I want to point out here. One is that I think it's really important to locate the tragedy in the right place. And the other is this notion that it needn't be an inevitable response. And I'll come back to that point at the end. Okay. But for now, to return to these two different kinds of agential questions, I think we can now make sense of this second kind of agential question, which is the following. In view of my life as a whole, what should I do? So this includes questions like, what do I want the shape of my life to be? What will I make my life about? What will I dedicate my life to? What would be a more or less meaningful life for me? And what is my identity in relation to others? And how should I shape my life in response to that? I also think that these kinds of questions, while we may make agential choices throughout our life based on these kinds of questions, at least some of us do, these kinds of questions loom especially large for life endings. I think life endings have a special significance. So we care about the last week of our lives more than we care about, just choose an arbitrary week of our lives. And so we can make sense of the fact that asking what role does my death play in the story of my life and what role do I want it to play in the story of my life can make a lot of sense to ask and is different from just, will I have another good day? Right. Okay. So, with reasons that answer questions about whole life meaningfulness in mind, what are some of the reasons that people with clinical depression have for wanting to end their lives? And so, here I want to first turn towards suicidology for a little bit of insight. So, Thomas Joiner's 2005 Interpersonal Theory of Suicide proposes that there are three factors that jointly predict suicidal behavior: thwarted belongingness, perceived burdensomeness, and acquired capacity for self harm. And what the empirical studies have shown is that perceived burdensomeness in particular is, in fact, highly correlated with suicidal behavior. And perceived burdensomeness scores also correlate with more severe clinical depression symptoms. So, what is perceived burdensomeness? Well, the way that it's studied is via something called the INQ, the Interpersonal Needs Questionnaire. And there are certain items on that questionnaire that target perceived burdensomeness directly. These are things like asking people to rate on a scale items like, these days, I think I give back to society, or these days, I think I'm an asset to the people in my life. Or right, these days I think I make things worse for the people in my life. Am I a burden on society? And these scores about perceived burdensomeness correlating with suicidal behavior are really one of the most consistent findings in suicidology. A recent meta-analysis on the interpersonal theory of suicide found that, quote, perceived burdensomeness may be a particularly robust longitudinal predictor of suicidal thoughts and behaviors. It's also worth noting that the same sort of phrase comes up um, when talking about people who are elderly quite a bit, and many older people report things like, my one remaining goal in life is not to be a burden on my loved ones. So this is a really pervasive notion, which is connected to a lot of suicidal ideation and behavior. Okay, so now that I've turned to suicidology, I want to return again to Ansluis and White's critique of suicidology and quote from them again. So here's the quote. Suicidology has consolidated around clinical intervention and risk factor analysis, sidelining structural, cultural, and historical perspectives. Joyner's theory exemplifies suicidology's preoccupation with individual level explanations, neglecting how racial capitalism, settler colonialism, and social abandonment shape suicidality. This reflects suicidology's continued reliance on predictive and interventionist approaches rather than interrogating the conditions that make suicide both thinkable and livable. So, with that critical lens now in mind, I want to turn to this same meta analysis on perceived burdensomeness. And I noticed when reading it that it gave these suggestions regarding treatment that was sort of tailored to um, these high scores on perceived burdensomeness. So, the suggestions were as follows. Um, Helping people with interpersonal effectiveness skills to enhance social support, restructuring negative automatic thoughts surrounding beliefs that one is a burden on others or on society, improving engagement in social activities, and reducing experiences such as insomnia that may increase isolation and thwarted belongingness. So I found this really interesting because even the ones that are talking about social things are highly individual, right? It's all about um right, even a person's own experiences with insomnia. Like maybe that's sort of the switch that we ought to flip in order to help with this feeling of perceived burdensomeness. Um or this sort of assumption that feeling like a burden is a negative automatic thought, which is a highly individualist notion where it's like, right, like we ought to change that thought because it's an automatic thought, not like a deeply well thought through sort of thing. Okay. So I quote now from this paper by Christoff, Raymond Sutter that analyzes the notion of perceived burdensomeness, but as an actual moral emotion. And I think that's really important. So here's the quote. The emotions associated with perceived burdensomeness are very difficult to play down or belittle simply by opposing them. They contain an assessment of the given situation that's backed by or strongly connected with altruistic care by the care recipient for the caregivers. The relationship contains a structural kind of reciprocity of caring attitudes. If it is impossible to change the situation significantly, the feeling will probably not go away. Disregarding, overlooking, or ignoring these feelings would put more weight on the wrong side of the balance and exacerbate the strain on the patient's self worth. So, what's important here is that this sense of perceived burdensomeness is, I think, sometimes a felt inequity that really can't be overcome by trying to think it away. Why? In part because it's an internalized moral injury that's produced by injustice that's further upstream, that consists in part in inadequate support for caregivers. And so, if that's the case, the question is this: how can we come to feel mutual respect and esteem in relationships with structural asymmetries and inherent dependencies? My first answer to this question is a negative one. So, not via neoliberalism. Um, so, they actually did a study in 2022 that I found really interesting that found that a person's having neoliberal values actually fosters a risk for suicide. And I'm happy to talk in Q&A a little bit about how they measured someone's neoliberal attitudes. But what they found was this: neoliberal values were associated with suicide stigma, Suicide stigma was then associated with negative attitudes towards help seeking, and those attitudes in turn were associated with high levels of perceived stress that prepared a context that fostered the risk for suicide. So, having neoliberal attitudes does the opposite of sort of what we want here. Instead, make two brief recommendations. Um, One is the notion of nested dependencies. So, the idea being that we need to move beyond the notion of this exchange reciprocity, and really lean into an ethics that's grounded in our shared dependency. So, in the well functioning society, according to, for example, Eva Kate, we're owed someone to take care of us when we're dependent. We're owed someone to take care of us when we take care of someone who is dependent, and our caregivers are owed the support they need in order to be able to take care of us. So, insofar as we don't have that, that's a function of, uh, well, not function, right? Not the well functioning society. Um, my other suggestion is this. The notion of access intimacy, I think, is relevant here. So, people who are in the throes of clinical depression need access and they need access intimacy, but they may not have conceptualized themselves as disabled in a way that would give them contact with these ideas that are from disability justice. So I think we need to help bridge that gap. So even things like tasks of daily living, like getting out of bed, brushing your teeth, etc., can sometimes become extremely difficult without help when you have clinical depression. Um, People from the disability justice community have a lot of insight about that. And in particular, this notion of access intimacy, especially as theorized by Mia Mingus. Now, she struggles to put it to words, but then she puts such beautiful words to it too. So I can't help but quoting her here. Access intimacy is not just the action of access or helping someone. We have all experienced access that has left us feeling like a burden, violated, or just plain shitty. Many of us have experienced obligatory access where there's no intimacy, just a stoic counting down of the seconds until it's over. Access intimacy is not charity, resentfulness enacted, intimidation, a humiliating trade for survival, or an ego boost. In fact, all of this threatens and kills access intimacy. There is a good feeling after and while you are experiencing access intimacy. It is a freeing, light, loving feeling. It brings the people who are a part of it closer. It builds and deepens connection. So, to sort of conclude here, I think it might not be enough to just say, someday you won't feel bad anymore. You've got a bunch of good years left. If agential decisions are sometimes about lives as a whole, shame and the structural barriers that produce it can cloud the possibility of recognizing alternative life narratives that are beautiful, meaningful, and worthwhile. So, what we need to do is to help alleviate that shame so that people can see these possibilities for their lives. And when those possibilities genuinely don't exist, we have an ethical obligation to make them exist by fixing society. Thanks so much.
Thanks so much for that, August. And you see lots of applause already in the Zoom shenanigans, which is great. There's already a few questions in the Q&A, and we've got uh, just under 10 minutes. Just waiting.
Bye.
Okay, slide is up and our faces are up. Yeah, we've got just under 10 minutes for our Q&A session, so I will get started into it. The first question in our Q&A box is from Hypatia Spa. How far do you think the medicalizing, irrationalizing view of suicide, that it can't be right, must be an illness, etc., impoverishes our own views on why we stay alive by never openly challenging it? This is the main reason we're in principle against non-consensual suicide prevention.
Wow. That's a great question. And difficult to answer all at once, I think. But I will do my best. So I mean, what's great about this question is that I have thought through, okay, I do think like there are ways in which we can be more or less irrational when we are experiencing certain, you know, however you want to characterize it, but you're deep in your depression. Um, but what's great about this question is the idea that if we have that really overly medicalized view of what's happening in mind, then it sort of loops back in on us, right? We can use that to discredit our own um deeper held beliefs and perceptions, right? So sometimes we might have a sadness, for example, about feeling like we're burdening someone. Um that is tapping into something, right? It's something structural, but we might cast it aside if we then have the really overly medicalized view um in mind about ourselves. So I think that's really important because that kind of self-doubt can have pretty profound consequences. Um, and many people have written really eloquently about this sense where you start to lose self-trust and the impact that can have on your functioning and your agency. So yeah, there's a lot more to say there. So thank you for that question. Mostly I just want to say, yes, I want to think more about that and lean into that. Thanks.
I'll just add really quickly in the chat that Hypatia added. Oh, sorry, I just have to move a thing. I also meant more fundamental questions about relations of life to the cosmos, the gods, history, etc. But yeah, that part is important. So yeah, maybe maybe you can all be in touch.
Yes.
I see August, your email is still up on the screen. So
Oh, good.
okay. Next question from Shay Welch. How does one respond to situations where people with severely debilitating and untreatable chronic illness actually have a negative holistic quality of life and so desire suicide, but people attempt to convince them that they should take an additive approach about the good moments to try to change their mind? It seems like different disabilities might have different relations to the additive and holistic versions of quality of life. Not an objection, just curious how it works in the other direction.
Yeah, that's an excellent question. One of the things that got me started thinking about this project a long time ago, um, was thinking about just how differently people talk about sort of some of the end of life, euthanasia, maid, et cetera, topics, and then talk about suicide outside of that context. And one of the things really does seem to be one of those early things I said about even if we take a medicalized version of clinical depression, th- there still are very negative things about it, right? That would impact your quality of life. If we think about it as a disease, um, eh, in a lot of other cases, people would say, like, okay, I can make sense of the fact that this person is saying they have a negative quality of life, and that might be a reason that they're trying to make an autonomous choice. Um, and so there's a dissimilarity here where there's this quickness to jump to you're not able to assess anything about the quality of your life accurately. So yeah. So there's that. Um, but I guess I will also say that even if you have a really sort of holistic view and you care about things about the overall shape of your life and what you're dedicating your life to, you might also care about some additive things too. So it might not be wrong necessarily to help someone to see some of these like small pleasures and like extra years. So there's nothing wrong in principle with a little bit of that. I think the most important thing is that we not immediately cast off someone's judgment about what they think is worth doing as being irrational just because the kind of condition they have is one that's mental in some sort of way. So I guess I would say that it's complicated. A lot of this is a little bit nuanced, and I also think people just differ with how much they care about these holistic things versus these additive things. So it may be a highly like individual, personal kind of conversation you'd have to have with someone who you really get and get to know, which is an important piece, I think. Thanks.
Thanks for that. Yeah, there was a tiny follow-up on that from Shay to add on to the question. The access to intimacy is what others will say are the good moments that the sick people should consider outweighs their global lack of quality of life.
That is a good point. Yeah. So they're right. Yeah, some of that does just involve good moments. That's
Yeah.
true. Yeah.
There's lots of questions, and I'm not sure we'll end up having time for all of them, but I'll get to C's next. So this is from C. Dalrymple Fraser. I wonder if you have any thoughts on how ageism fits into this picture. I have in mind, one, that ageist normative conceptions of a life course positions younger and older people as less autonomous, less rational, and more reliant on others, which may contribute to perceived burdensomeness. And two, that appraisals of what's lost in death often rely on a version of the formula like future quality of life times quantity of future life that tends to view youths as losing more through death for the fact of quantity of years lost and hope that in the longer available future, things will change.
Oh, what a fantastic question. Thank you so much, C. So I had another slide that I had to cut for the sake of time that used part of the response to the show 13 Reasons Why as a basis for the foil I was constructing. And I think that's super relevant here because one of the sources of backlash to that show was the idea of having reasons why, as being like, no, 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 it's not about having reasons why. It's about people having clinical depression, which is this disease that gets in the way. But I do think there's something there about the fact that we're looking at younger people, and so we're jumping to irrationality. Um, and that also can explain some of this disparity about thinking about end of life cases in the sense of someone who is older who's facing a terminal illness of some sort versus other cases of suicide. So, absolutely, I think there's a lot to unpack there. And I think from sort of a disability justice perspective, it's really important for us to look at how we're valuing lives of different lengths. Um, and what value there can be in sort of a whole life narrative and a whole life story in a life that's shorter than the average life. And that's sort of a direction that I would like to tap into more on this. So just thank you for the question.
All right. So there's 2 minutes left before we have to move on. I think we can squeeze in one more question, but I just wanted to make sense. There's a couple more. There was another question from Hypatia, and there's a question from Ed Smith that probably won't have time for. So take a look at the Q&A afterward and see if you want to respond in there. But from Julie, it seems that many of the reasons, from Julie maybe, it seems that many of the reasons for why people feel like burdens depend on peculiarly Western values, such as the belief that being independent and physical tasks, such as toileting, is necessary for a dignified life. In many cultures, a dignified life is by contrast associated with moral goodness. And in such cultures, needing physical help as one ages is regarded simply as something that can come with aging, not as a loss of dignity. Do these sorts of cultural analyses make a difference? You've got about
Well, absolutely,
That's
yes.
all.
So I can answer that quickly with yes. I think absolutely. And one of the things that I take away from Mia Mingus's work on access intimacy is this there's sort of you hold fixed a lot of the same things that can bring about a feeling of perceived burdensomeness, right? But it's almost like you transform that emotion or that perception into something with the opposite valence. And I think that's really only possible when you change some of these societal and cultural values, or at least how you're thinking about the societal and cultural values in order to have a feeling of dignity within that dependence. So, short answer, yes. And thank you so much for the question.
All right. I'm so sorry to cut off the questions there, but I want to make space for our third speaker. Let's everyone thank August for a great talk and a really interesting Q&A session.
Thank you so much.
All right. Lots of applause in the Zoom, which is great. All right. Uh, Uh, Everyone, our third and final speaker is Clarissa Müller-Kosmarov. She's a PhD candidate in the Department of Philosophy at the University of Warwick in the UK. Their doctoral thesis presents a critical phenomenology of othering, bringing together key aspects of Merleau-Ponty's phenomenology of embodiment and Gadamerian hermeneutics to develop an account of othering as a perceptual and interpretive practice. More broadly, they're interested in the philosophy of disability, particularly philosophy of neurodivergence, social epistemology, and the writings of Michel Foucault. And most recently, they've been working with Dr. Robert Chapman on a neurodiversity and philosophy entry of the Oxford Research Encyclopedia of Disability Studies, which is forthcoming. So Clarissa's presentation is called Phenomenal Fluctuations and Bodily Uncertainty Toward a Phenomenology of Episodic Disability. So all yours, Clarissa.
Right. Thanks so much, Jane. And huge thanks to everyone, the organizers and everyone who's helping with the conference. Immediate apology for the lighting. I'm in the UK, so the sun sets at like 3 in the afternoon. But hopefully you can see me okay. It is not too difficult. So yeah, as Jane already said, my name's Clarissa. I, in terms of presentation, am a white, femme-presenting, non-binary person. I have short brown hair with a bleach section in my fringe. I'm wearing a green jumper and I have some golden jewelry on. Aside from the disclaimer about the lighting, I feel like I should also open up with another immediate disclaimer about this talk, insofar as when I initially kind of was thinking this through and presented the idea to Shelley when she invited me to present, I think I was perhaps a bit ambitious in focusing on episodic disability in that more general sense. But that, yeah, for a 25-minute talk, perhaps a bit ambitious. So I've focused the scope a little bit to focus more on the physiological side of episodic disabilities. And I'll be using Ehlers-Danlos syndrome, or EDS, as kind of like an exemplar case of this as I go through the talk. So the purpose of the talk really is kind of twofold. The first is to kind of both engage with, but also critique a little bit phenomenology to reflect on what is referred to as episodic disabilities, and to discuss a bit how such experiences of the body kind of pose a bit of a complication or maybe a kind of problematic for traditional phenomenological accounts of the subject or of the self, and then to also consider a possible path forward beyond those problems, because I do think that they are possible to solve. So, definitions up front. What is an episodic disability? So in short, this is a term for disabilities that are characterized by persistent or chronic, but non-continuous symptoms, whether in presentation or severity. So these are typically conditions where you have periods of kind of maybe relative wellness, and then periods where symptoms or the severity of those symptoms are increased. And these would be referred to as like flares or episodes. As I kind of alluded to, this can encompass both like physiological and psychological or mental conditions. So like PTSD, depression, these could be examples of episodic disabilities just as much as like arthritis, Ehlers-Danlos, and things like this. So I'm just looking at my notes. So as I said, I kind of narrowed the scope a bit, and I'm focusing more on the physiological side with specific reference to EDS. And EDS, for those of you who maybe don't know, is a systemic connective tissue disorder. There are around like 13 different types, but the most common is hypermobile EDS. And generally speaking, EDS is characterized by excessive mobility in the joints due to the poor connective tissue, including subluxations and dislocations of the joints, chronic pain because of that, as well as chronic fatigue, digestive problems, fragile skin, poor wound healing, muscle tension, migraines, general dysautonomia, hernias, and things like this. So EDS, like all episodic disabilities, is characterized by a persistent set of symptoms, but not necessarily the continual experience of those symptoms. So the severity could increase or decrease, new symptoms can arise, and so forth. So in short, they're just quite unpredictable and can fluctuate quite a lot, both from individual to individual and under the whole kind of umbrella as well. And it's my own experiences really of this unpredictability and these kind of bodily changes that got me thinking, one, of how we think about disability kind of generally, and how we think about kind of what it means to be in the world, what it means to be a self or to be a subject. Because I think that conventionally, our understanding of disability tends to be quite categorical. So one is or is not disabled. Disability means you cannot do certain things in a categorical sense. But then when we look to episodic disabilities, that doesn't really seem to be the case. Insofar as we have this frequent refrain amongst people with episodic disabilities, that it's not that we can't do certain things categorically, but that we don't know whether or not we can, regardless of whether we have in the past. So there's a lot of uncertainty and ambiguity that seems really central to the experience of many episodic disabilities. And this uncertainty and ambiguity makes it very hard to plan, hard to have confidence in one's body, and to feel like one kind of has a firm grasp on what you can do and when you can do those things. So alongside this as well, we have on one hand, like episodic disability not really seeming to fit within that kind of prevailing image of disability. But it also seems to kind of contravene or problematize or kind of not kind of cohere nicely with prevailing Western understandings of both the subject and the self. So here I'm thinking of works from people like Descartes or Kant, as well as Husserl and Sartre, who kind of en masse or like in some present an image of subjectivity and self as something quite singular, as coherent, as stable, maybe as this open, possibilizing, transcendent thing, whose transcendence typically owes to that singularity and that stability. But episodic disability doesn't really seem to fit into or isn't kind of made intelligible within this framework. I think due to the instability and unpredictability that's quite characteristic of episodic disability. And as a phenomenologist, of course, that's the direction I come to this kind of question from. And phenomenology does retain many of the commitments of people like Descartes and like Kant, specifically the kind of dualism, the idea of the rational subject and this idea of the singular and single subject. So in Husserl, for instance, we have subjectivity as the transcendental ego, as the identical pole of intentional acts. There is kind of an odd one out, depending on your reading, and that for me would be Merleau-Ponty, who takes a much more kind of situated and kind of contextual approach. But I think that there's some potential issues with his view of subjectivity too, namely in what he refers to as the body schema and its operational dependence on habit. But as I've already said, I do think there's also a way out of those problems. So Merleau-Ponty really does depart from that kind of classic Cartesian cogito, and he understands subjectivity as necessarily embodied. So it's the body's directedness toward and situatedness in a given environment. That's the foundation for subjectivity. So it's not a mental process or a mental act. And the body schema is really foundational to this understanding of subjectivity. And Merleau-Ponty defines it as, quote, a global, practical, and implicit notion of the relation between our body and things, of our hold on them. And that's from the primacy of perception. So it's the body schema then that gives us a structured sense of possibilities for our actions. So for instance, that I don't have to kind of consciously think through the forces or the distance between me and another object, like my water, for instance. I just intuitively know, or I have an implicit knowledge of all of those things without having to kind of engage in kind of conscious thought. That owes to the body schema. And there's a lot that really could be said about the body schema, but for the purposes of this talk, I'm just going to cover like really three central things which I think are helpful. The first is that it's the body schema that gives us a sense of intersensory, spatial, and temporal unity to experience for Merleau-Ponty. And this is because for him, his gestaltist comes out, and the body schema is meant to be, or should be considered, a form in the gestalt sense of the term. So that's one thing. The second is that the body schema is necessarily both stable and dynamic. And this is because the body is always changing. So both physiologically, we age, but also in terms of its situation. Like we're not always located in the exact same situation. And because of this, the body schema needs to be able to respond dynamically. And we see that it does in our kind of lived experience. But this dynamic organization of the body schema also offers a sense of kind of equilibrium or stability throughout those changes. But we should also understand that equilibrium isn't absolute. It's not achieved once and for all. Connected to this idea of the stability and the equilibrium, then, is the third and final point that I'll mention here, which is that the body schema is informed by habits or habitualization. And it's these habits that structure the body schema, expanding and delineating what the body experiences as possible and also as normal. Our habits kind of give us a sense of like the status quo. So for instance, that I have upright body posture and have throughout the majority of my kind of conscious life, that gives me a certain sense of a normal orientation, which would be disturbed if I was to suddenly start like walking around in a handstand. And these habits are the kind of automatic, unconscious postures or actions that we fall into when we're faced with a familiar situation. So classic examples would be when we're driving a car, when we're typing, when we're dancing, things like this, which we don't think about consciously when we do. Although disruptions to those processes can kind of bring them to our conscious awareness. So it's the body schema then that provides us with a reliable sense of where and how the body is spatially and temporally positioned, as well as providing us with a tacit understanding of what our bodily possibilities are at any given moment. And it's because of this that for Merleau-Ponty's subjectivity is an I can rather than an I think. And I do think that there's a lot to like about Merleau-Ponty's account. But I think when we consider the lived experience of episodic disabilities and EDS in particular, some issues do kind of arise that we should stop and consider. So just to really summarize then, the body schema is kind of characterized by this sense of openness and possibility and this implicit bodily articulation. It's informed by habits that coalesce into stable dispositions that give us an unconscious sense of possible action. But with EDS, we frequently don't experience our bodies as open, unconscious horizons of possibility. And we frequently cannot rely on our habits precisely because our bodies are so unpredictable and so changeable. So rather than being characterized by this kind of ease or stability and possibility and this kind of unconscious operation of the body schema, it more seems to be the case that the EDS bodies or the EDS body schema is characterized by like difficulty, by kind of maybe excessive instability, by ambiguity, and by conscious deliberation. So maybe there's a kind of an adaptation of the I can into a I don't know if I can, even though I have before, or something like this. So EDS then, and I think episodic disabilities more broadly, kind of is both maybe characterized by and or results in this kind of profound doubt in one's body and an ambiguity toward the body, because you're never entirely sure if your body can be relied upon. So to kind of put this in Merleau-Pontian terms, the kind of habits that undergird the stability and the unity of the body schema don't really seem to be reliable. By way of an example, there could be moments when I can carry my like grocery bags, my shopping bags, and that's absolutely fine. I can, walk around the campus or whatever and not, there's no problem. But I could wake up the following day and those same activities are just not possible for me due to the amount of pain or problems with my joints or whatever it might be. And there isn't really a clear indicator to the circumstances as to why this is no longer possible. So in this way then, EDS and maybe episodic disability more broadly can result in contradictory experiences of oneself or of one's body due to experiencing oneself as having different attributes, even when the circumstances are the same or similar. And I think that together, this kind of bodily doubt, this uncertainty toward the body and the ambiguity that we have toward it, and this contradiction can produce almost like an existential doubt as to the kind of person that one is, owing to this kind of incongruent experiences. It can kind of maybe lead you to questioning like who the real version of myself is. Like, I thought I could do this thing and I can't. I thought I was this person. Maybe I'm not, which is maybe quite obviously distressing, to say the least. So we kind of have this picture then And I think on one reading, we could say that the body schema of people with EDS or episodically disabled people, maybe are compromised in some sense or like underdeveloped or something like this, which if we were to adopt that reading would then mean that episodically disabled people wouldn't be able to have coherent experiences of themselves and the world because it's the body schema that is kind of what's bestowing that unity and that stability and that kind of coherence. Now, I would not want to endorse that reading for a few reasons. The first being it's kind of obviously ableist, kind of adopting this view that disabled people are underdeveloped or less developed in some sense. That's not a view I would want to endorse. It also inadvertently endorses the kind of implicit normative assumptions that are in Merleau-Ponty's account. Many people, Butler, for instance, Gail Weiss, and many others have brought attention to this, that what Merleau-Ponty kind of presents as a neutral body schema is perhaps rather a white male able-bodied body schema. And adopting this kind of a view would just kind of endorse those claims. But beyond those more kind of surface level things, I think there's two other points that we should kind of poke a little bit more. The first is that it's not really clear that bodily doubt or unpredictability is such an atypical experience, right? I think that able-bodied people also experience this, albeit in different ways. So I think of Iris Marion Young's paper, Throwing Like a Bell, in which she kind of develops an account of female embodiment, characterizing or understanding it to be characterized by like bodily doubt and this kind of heightened self-consciousness. So it's clearly not just a unique thing to disabled or episodically disabled people, though maybe these people experience it with greater frequency, something like this. And the second point is that it also is kind of related, is that it seems possible for all people to have difficulties with like configuring their body schema, shall we say. I don't think this is unique to disabled people, episodic or otherwise, though again, perhaps something experienced more frequently. So for instance, if you're used to driving on one side of the road and you travel to a country that drives on the opposite side, you would equally lose that ability to rely on those bodily habits. And you would need to reconfigure your body schema, and that could be quite difficult. So where does this leave us? And where does it leave phenomenology? Do we need to abandon it entirely? I don't think so. I do think that it can be written. My overarching takeaway, really, when I was thinking all of this through, is that the kind of unpredictability and the fluctuations of the episodically disabled body, that they can't readily be made sense of within our existing frameworks of subjectivity or selfhood. I don't think this is a fault or should be attributed to like a deficiency or an inferiority of episodically disabled bodies or disabled bodies more broadly. But I rather think this kind of intelligibility or something is owing to a failure of the framework. And I think specifically it's a failure of the framework to kind of adequately capture the dynamism of all bodies, selves, and subjects. I think it's due to this kind of single restrictive view. And so when I was thinking this through, I turned to Latina feminist phenomenology, which is excellent, and specifically the works of Gloria Anzaldúa and Mariana Ortega, and their respective accounts of the multiple or multiplicitous self. For the remainder of 5-ish minutes that I have, I am going to be kind of using these two things interchangeably, but it should be noted that there are like important distinctions between their respective accounts, but I'm not going to that yet. But their idea, or like the kind of main thrust of their idea, of their accounts, is that the subject of the self is inherently multiple or multiplicitous. So it's not a singular thing. And it's multiple because it occupies multiple social positions and backgrounds that aren't reducible to one another, but are rather kind of deeply intermeshed. So it's not that I'm non-binary or that I'm disabled or so on and so forth, kind of as separate aspects of myself. It's all of those together, this unique combination that gives me my particular perspective on the world, and we can't really disentangle those things. So because of this, the self should be understood on their account as decentered, So none of its identities or facets, if you will, are a priori central or most important. There's no kind of primary identity that negates or undermines others. And most importantly, the self is in a constant state of becoming. It's not a fixed, static, single or singular thing. It's a constantly evolving, constantly becoming thing. And I think that working from this perspective is incredibly helpful for some of the problems that I've identified. First, with regard to the kind of ambiguous or contradictory experiences. Within this account of the self, these problems are no longer problems, insofar as there is no contradiction, or at least there's no ontological contradiction, because there's not one self that's split into two irreconcilable parts, but just different aspects of one thing, which are activated dependent on the context in which they find themselves. So on this account, this kind of contradiction that we see isn't, as I said, isn't an ontological contradiction, but rather kind of arises when the self entertains both interpretations of themselves at the same time. So it's not an inherent contradiction, but the result of reflection. This isn't to say that that's not distressing. It can still be, but at least it's not kind of positioning people who have these experiences beyond kind of subjectivity or selfhood. And my second kind of point here is that I also don't think that this view of the multiple or multiplicitous self is kind of incompatible with the Merleau-Pontian embodiment that I think is actually generally quite helpful for conceptualizing subjectivity. It maybe just involves reading it in a certain way or supplementing aspects of it. And to do this, we can actually turn to someone whose works influenced Merleau-Ponty's account of the body schema, and that's the works of Schilder, who argues that the plasticity and the dynamism of the body schema necessitates not just one, but multiple schemas that are retained and which can be recalled. And he has a more developmental account, basically, where as we're developing, we'll kind of engage in this non-linear iterative process of forming and reforming new and different body schemas that can be reactivated essentially, dependent on the context. So maybe we go back to a place which we frequented as a child, and we kind of have this spectral, I don't know, or we're kind of haunted by the sense of a past version of our body that could take up that space in a certain way, or navigate that space in a certain way. What's more, and this is the kind of last point really, is the dynamic responsiveness of the body and of the body schema also means that some instability is necessary to the body schema, because an overstabilized body schema wouldn't be able to respond to environmental or bodily changes. So this means that instability and fluctuation isn't abnormal, but is rather just an integral part of our being, which I will put an asterisk here, perhaps is more frequent and indeed more distressing for certain people, dependent on the context in which they're in and how they're able to navigate that space. And by able, I mean how is society arranged such that relative ease of movement can be accommodated, and things like this. Because famously, employment, education, and so on and so forth kind of requires you to be quite consistent in how you operate, and that can be really challenging for people whose bodies and minds and so on don't kind of meet that demand. So final thought here, just before I close, really, is throughout the talk I've kind of been advocating, I suppose, in a way, for a depathologization, perhaps, of episodic disability. But I want to be very, very clear that I don't think that kind of more fully recognizing the dynamic and multiplicitous nature of all bodies, that doesn't mean that we should dismiss the distress or the pain and the many other challenges of episodic disability. I think that that's something that we should still take very seriously and that ought to be acknowledged. Rather, I think acknowledging this kind of dynamism and this multiplicity is helpful for producing more inclusive, perhaps more accurate ways of thinking about ourselves and other people, and that in turn helps to destigmatize different bodies by changing how we conceptualize the foundations of what it means to be in the world and what normal is, as well as kind of adjusting the lens on a more like meta level with regard to how we as philosophers conceptualize ourselves and in turn other people.
Great. Thank you. Thank you so much for that. It's great to see applause coming up on the Zoom
Thank
system.
you.
So, all right, we've got 13 minutes for questions, which is piles of time. So first question from Hypatia Asfa, and it has a question and a follow-up, and I'll read out both. Do you think that if the singular model of the self is an issue for situational disability, that the attempts to plural theories of subjectivity can be useful for this topic? All right, so the question kind of went up at first at 12:43, and there was a follow-up as you mentioned, Azaldua and Ortega. So do you think that if the singular model of the self is an issue for situational disability, that the attempts to plural theories of subjectivity can be useful for this topic? Is maybe here the body itself also viewable as, within the situational disability, a multiplicitous live, even with a singular self as a correlate? See how, for example, in plurality, different headmates can have different senses of sight, but here would be the same single headmate at different times. And then the follow-up, to clarify, we don't do the kind of work of feminist phenomenology you referred to, since by your account that is not a plural theory, multiple selves, but of one internally differentiated self. Our theories are of multiple selves, plurality, multiplicity, and thus also multiple lives, an outer versus inner world, and in between alters between images and body sensations, and ask how that could be helpful for the description of situational disability.
I will try to answer this somewhat coherently, hopefully. So with regard to like the plural singular split, I guess I'm flip-flopping, right? Because on the one hand, like I'm convinced and not convinced by both in different ways. And so I've yet to kind of definitively choose a side. I am obviously critical and skeptical of the kind of really traditional view of the singular kind of self that we have. I think it leaves a lot out, and that can and has had quite disastrous consequences. But then when I entertain that more kind of plural, like truly kind of multiple rather than multiplicitous version, like of the self, that also can kind of raise some problems too with regard to like the kind of coherence of experience and things like this. So I don't know. I would need to think more is my answer to that part of the question. But yeah, regardless of whether we're kind of adhering to this kind of strict kind of unity or singular view or a more plural view, I do think regardless of that, that engaging with the idea of the multiple, regardless of how ontologically deep we take that, or in what way we take that, is incredibly helpful and like necessary. I would say. I think we do need to attend to that quite profoundly because, well, it just seems to be the case that we are more than just one thing, and that the intersections of those various aspects of ourselves and how they intersect with the different contexts that we're in is kind of an indispensable part of the question.
Yeah. A quick follow-up from Hypatia over in the chat. I mean, if you're not plural, you're not plural, but as a plural system, we do have to conceptualize ourselves that way. It's not really a theoretical question for us. We have to understand ourselves as differentiated to even explain basic splits like headmates with different sexualities, etc. So yeah, it might be interesting to have some back and forth by email later on. Okay, so question in the Q&A from Shay Welch. A flexible body schema results in a very different perception of time, which falls into crypt time. So deep ontological crypt time. How do you think this contributes to your approach to dynamic subjectivity?
I think this is a really interesting question. I've been thinking about time a lot recently. I think because I struggle with time, I have ADHD and I do have issues with just perceiving or, I don't know, understanding the passing of time. It's all out of whack. If I didn't have timers, I would be nowhere. So yeah, this is something that has been on my mind, albeit in a slightly different perspective. But oh, sorry, I see you from Cal. Oh, bye, Cal. Yeah, I think that you're right. Especially, I don't know, I go back to my like Husserlian reading and I think about how the kind of phenomenological view of time stems from there, and how that would be complicated or kind of rendered very different within a more multiple reading. To be perfectly frank with you, I haven't thought about this in any great depth, and so I'm not sure I have anything super sensible to say on the topic, other than, yes, I think that that's a super interesting question. I would like to think about it more, and would love to hear your thoughts on it if you have more sensible things than me to say.
Great. I hope you saw this in a little heart that that came out from Shay. So that's great. Next question from Karen Boxer. Do you think it's best to understand the instability of bodily ability over time as on a spectrum, with those with episodic disabilities showing greater instability?
Right. Yeah. I think that is something which I have in mind, because it seems to me, so I do think that the claim that all bodies have some kind of instability, I think that that is the case. So at a baseline, there's some instability, because otherwise we would have this overstabilized thing, and we wouldn't have that responsiveness, which we just see evident as we exist in the world. So that has to be the case, I think. But now, like, the kind of frequency of that, or like the profundity or something of that instability, I think that is in question. And I think, again, like the social kind of context which we find ourselves in has a really important role there. I think Ortega kind of puts it really well in her discussion of the multiplicity of self, and how she understands this instability being like really exacerbated when you find yourself kind of in a state of unease based on your kind of setting, right? And that can bring that out to greater or lesser extents, depending on how like conversant you are, or how kind of welcoming your environment is to maybe you making, like, let's say, like social taboos or something. So yeah, I think that seems very much to be the case, and that's also why I think it's important still to acknowledge like the distress, and like the other challenges that disability frankly poses, right? Because it's one thing to be like, oh, we'll have some instability, that's fine, and then move on. I don't think that that's what we should do, though. I think that we need to take people's experiences seriously. So yeah, I think that maybe some kind of a spectrum is the way to think about it. But at the very least, that there does seem to be like a sliding scale or something like this.
That's great. Thank you. There's a comment over in the chat from Miss Sharia that I'll just share. So interesting. It seems that the singular notion of the self has been shaped by capitalism's demand for docile bodies that are easily categorized and sorted according to their value to capital, as you alluded at the end of your talk.
Right. Yeah, exactly. Yeah. Like, that's what I say. That's just, yeah. Yeah.
I'm gonna take sneaky advantage of the fact that there's still like a few minutes and ask a question of my own. So I really enjoyed your talk. I found the sort of project super interesting. Oh, Julie has a question. Okay, I'm gonna ask mine super fast so that we can move on to Julie's. And that's I've been wondering, with respect to like some of my own work on like gut issues, and I also have migraines and all this sort of stuff. I've been wondering whether we can kind of pull some of the habit talk from phenomenology into talking about like meta level habits that we develop about checking in with our bodies, having a sense of like, is this going to be like a good day or a bad, like those sort of meta level kinds of checking ins, having a sense of like, oh, can I push through this one or not? Whether that's a way of making some of this habit work go further, even when the body is very unpredictable.
Right. Yeah, I think that would be really interesting. Yeah, because like the role of habituation within phenomenology is like, at the one hand, like very kind of a simple thought, but at the same time kind of profound in a sense. And I think that is very interesting, because I'm hesitant to say entirely that, you know, disabled people, episodically disabled people, can't rely on their habits at all. I don't think that that's the case. Like, there is still clearly some reliance going on. But yeah, I don't know. I think that would be a really interesting application to think about it in that sense of like the vetting process that one goes through, right? Where it's like you wake up and you're like, okay, what are we dealing with? You know, like, and you're going through it, and so I think, yeah, that could be a really interesting way to to bring, as you say, like to bring the kind of habituation part of phenomenology out in kind of, I don't know, get a bit more out of it in a sense.
Thank you. Okay, so we have a question from Julie, although I quickly just share that comment from Shay because it does sort of follow up. That's a bit of what I mean about ontological time. We can't live in a stable trajectory of time at any time. I explain I live my life hour to hour. It's a constant reflexive
Right.
engagement with time, what's available, how to inhabit, how it makes living possible at all at that time.
Mm.
All right, so question from Julie. We've got 3 minutes left of our session. This is great. From Julie Maybe. There is some evidence that, at least in some cultures, bodies are experienced as essentially socially shared. It seems possible that the experience of the body is always socially defined. Would such phenomena or views affect a phenomenological account?
I don't think so, is my like intuitive response. Purely because at least the kind of Merleau-Pontian like view that I kind of work with is like deeply socially situated. Like for Merleau-Ponty, there isn't really anything that can exist beyond or outside of it, or in some sense the social setting. So I don't think that would be like inconsistent in any meaningful way. Rather, I think it would be very much of like, okay, like yes, like it does dictate how we think about these things and how we experience our bodies, and that, you know, doubtlessly, if you follow the view of embodiment that I do, that doubtlessly has impacts on how we experience ourselves and others and the world in general, and the kind of affordances that we are presented with. So yeah, to me that would be like deeply compatible. Yeah.
All right, thanks so much. Okay, I'm just checking for any other questions in the chat and any questions in the Q&A. And currently there's none, but it's 1:09 and the session is at 1:10. So I feel like this is all coming together beautifully. So everyone, let's thank our last speaker, and let's in fact just a round of applause actually for all 3 speakers. This is a great start to our day.
Yes, thanks very much. It's been a wonderful session. I think that the papers, although they were quite different from each other, fit together so well to make the session work very well. So we're going to take, well, I guess a 5 or 6 minute break, and we will return to a session chaired by Tracy Isaacs, entitled a panel entitled Allies, Animosities, Besties, and Betrayal, with Lena Gauthier-Manuel and Christine Rodier. So see you in a few minutes.